this is obviously important. يعني tell me if the voice is not clear or anything's not clear من ناحية الaudio visual, okay? Let me know. Asthma is important, and I think we're going to go over the burden of the disease. We're going to talk about the pathophysiology, we'll talk about the subphenotypes, and we'll talk about the treatment algorithms. The word asthma comes from wheezy, asthma from panting or breathlessness. It's a Greek word. And the concepts of asthma highlight breathlessness, shortness of breath, respiratory symptoms that are recurrent and subacute. I think it's important to understand that asthma now, we used to look at it in a very traditional sense as it's it was as a single disease, but now you have to understand more as a syndrome. It's multiple diseases, which we blanket the term asthma around it. There's the more common phenotype that we see, which we'll talk about it. There's an acute and there's a chronic component to it. With the chronic component actually showing not some chronic changes to the lung if it's poorly treated. So there is long-term consequences if you don't treat asthma in patients. So, we used to think it's just acute and that's it. You've treated it, gets better. If you don't treat it, it's not a big deal. You treat it later. But now it turns out, no, if you don't treat it over a long period of time, you have chronic remodeling of the lungs. It's a childhood disease for the most part. So that's where you see the biggest burden in the pediatric population. But in Saudi, you see it across the whole society. So let's talk about the burden of disease. And I think this is a big part of the asthma problem is that it's one of the most prevalent diseases in the world, actually. It's significantly associated with mortality and morbidity, with hundreds of thousands, if not millions of deaths a year. But just it's tough to account for because most asthma is actually under-recognized. Most people who have asthma are actually not diagnosed, and most diagnosed asthmatics are poorly treated and poorly controlled. So it's important to understand that this disease is something we haven't done a very good job with. It leads to extensive amounts of obviously lost work, decreased exercise tolerance, lost functional ability. So it affects people's lives and livelihoods, other than obviously causing them direct mortality. We do see some significant distribution of asthma in specific populations. We see it more in more data in North America and African Americans and Latino patients. It's again more prevalent in children, more so in women. We see more asthma in industrialized countries, which is suggestive that maybe industrialization is a big driving factor for asthma. Maybe exposure to pollutants, etc., factories, etc. All of these things might be contributing to the burden of the disease. Rather than rural communities, we see less asthma prevalence. So a lot of it is environmental factors that are increasing the rates of asthma. So what about the burden of disease في الأزمة في السعودية؟ I mean, ما في شخص في السعودية ما يعرف شخص إلا عنده رب، أو ما في شخص في السعودية أتوقع ما عنده أحد أهله ما عنده رب. And that's pretty true. The burden is very high. And if we're talking about maybe 25% of our population have asthma or put to the diagnostic criteria for asthma. And it's obviously based on a lot of things, such as our environment, obviously a big one of it, our diets, our genetics, our exposure, and the health of the environment around us as well. And we do see there's not a lot of great data, and I haven't really updated this, but actually the prevalence is very different across regions. في مناطق where the asthma is a lot less, and if the same, it's very quite low compared to somewhere like El Hafuf, where it's very 1 in 3 people have asthma, which is a huge burden of disease. So it's significant. It's an important disease, and you need to understand it because it's in every part of your everyday practice. So how do we classify asthma? Well, like I said, it's a syndrome, but now there are multiple diseases. The most common one is the atopic, or also known as extrinsic or allergic asthma, which is the IgE-mediated asthma, which is most patients have. It's usually due to exposure to environmental agent that causes histamine release, dust, pollen, food, etc. Usually there's genetic and familial tendencies in it, usually associated with increased IgE levels, with positive skin testing for atopy. To help diagnose the allergen. And then the rest of it is non-atopic asthma, which is many other diseases, but with the same sort of phenotypical expression where they still have the wheezing, shortness of breath, etc. But the response to therapy might be different, though, and the causative agent is quite different. Some of it is triggered just by infectious diseases. There's usually no genetic predisposition to it, and it's non-familial nature. Anyways, there's a subtype of asthma within this 30% is the aspirin-induced asthma, which is the COX-2-induced asthma. And I think this is an important subtype to understand because, الناس يقولون دائما أنت تركب ولا تأخذ NSAIDs. And even physicians will say that. You'll see even consultants say that. That's actually not true. Only this subtype of asthma with the COX-2 inhibitor, like precipitated asthma, they're the only ones who actually get worse when you give them NSAIDs, and that's a very, very, very small percentage of asthmatics. So it's it's really unfair to most asthmatics to say you can't take this very effective pain medication or anti-inflammatory because we don't understand this disease. Whereas most of them will not do anything except work as an effective pain medication or antipyretic. We have to understand that most asthmatics don't actually have issues with taking NSAIDs. So what's the pathophysiology? I'm not going to spend too much time. There's an acute and chronic aspect to it. There's a chronic inflammatory process and acute airway hyperresponsiveness. The inflammation is due to migration of T cells. I'm not going to get into too much of the details. And causing edema in the airways and structural changes over a long period of time. This is caused by multiple factors, like I said, and atypy, genetics, etc. Environmental factors that we talked about, such as infections, pollution, and allergens. And the acute response is the bronchospasm that we see, which is the superimposed usually on the chronic changes that we have, which gives you the acute asthma exacerbations. You can read more about that. So, what are risk factors for asthma? Well, the risk factors are essentially, we generally talk about risk factors about things that are modifiable and non-modifiable, because things that we can change and things that we cannot change. What are things that predispose patients to have asthma? Well, definitely, like we said, genetics of atopy and people who have allergies usually are more likely to have asthma, obesity, gender, environmental risk factors. These are partially changeable, like exposure to specific things. We often see like allergens, tobacco, infections, diet has all been implicated in increased rates of asthma. Occupational exposure is quite significant as well. We definitely see people who work in any sort of industry where there's a lot of pollutants have increased rates of asthma. Miners, people work in gas fields, etc. So some of it is avoidable, which are the triggers. The triggers are essentially the same things. It cause a chronic disease and cause acute exacerbation. So it's important when you see an asthma patient to understand what's triggering their asthma, so they can avoid it, assuming it's avoidable, or they might need to change their lifestyle or their job, etc. So how do we diagnose asthma? Does anyone know how we diagnose asthma here?
By sound, breathing.
By breathing?
Sound of breathing.
By history and examination.
Okay. Any other answers?
LFTs, lung function test.
You mean PFTs, pulmonary function test?
Pulmonary, yes.
Sure.
Spirometry.
Okay. So can you imagine doing PFTs for everyone? And we heard spiral. Okay, so there's different answers. So I think it's important because the disease is so prevalent. Really, it is more about history than anything else. Because somebody said, we examined the patient, but they might not be having an asthma exacerbation now. They might be telling you, I just don't sleep well at night because I'm coughing a lot. And you would listen to his lungs. He might have nothing in his lungs right now. He might sound fine, might not be wheezing because his exacerbation might only be at night or only when he's exposed. So it's mostly about history and response to therapy. That's generally how we do it because it's so prevalent. So if you have the constellation of symptoms, something, with shortness of breath, dyspnea, coughing, whatever it is, or it's more difficult in pediatric patients, and then you give them like a rescue therapy, and it helps relieve their symptoms. And that these patients have asthma. That's really how we diagnose most patients. And then the PFTs are the gold standard test. That's when we're not sure if this is asthma or something else. Is it bronchiectasis? Is this COPD? Is this interstitial pulmonary fibrosis? There's many pulmonary diseases that are chronic in nature. So the PFTs is to confirm the diagnosis when there's a question about it. And spirometry is really not a diagnostic test per se. It's we use it more as a way to evaluate the severity of asthma and response to therapy, because it just checks one aspect of the pulmonary function, which is forced expiratory volume, is how 1 minute how fast you can breathe out. So it just checks one aspect, doesn't tell you about the rest of the function. So we use it to say, are you responding to therapy when we're treating your acute asthma? Does that make sense?
Yes.
Okay.
Yes, doctor.
So clinical manifestations, and response to therapy. This is how we diagnose asthma. So what are the clinical manifestations if you were to see someone who has an active asthma exacerbation? Well, like you said, it can be increased work of breathing, abnormal breath sounds, accessory muscle use, and just could be normal. And that's, I think, a big problem is that we often forget that if they're not having an exacerbation now, they will be normal. They'll have no findings on physical exam. They shouldn't. And then there's classification for asthma as a disease in general. This is basically on severity. And the classification is used to decide escalation of therapy. And we'll talk about therapy because that's important. So this is like the different clinical manifestations. Just understand, and like very old, elderly patients and very young patients, it's very difficult to diagnose them because they can't tell you that they're having shortness of breath. Sometimes they can't, or they have multiple. They have like heart failure as well. They have other diseases that cause. So sometimes it's difficult to make that diagnosis. In a kid, it might just be they're just not sleeping well. They're very fatigued. They're just very irritable. It's not always simple to make the diagnosis. PFTs again are the gold standard for the diagnosis. Okay, so we use that to you see airway reversibility with an obstructive pattern. I'm not going to ask. This is not part of our howler per se. That's more internal medicine to understand how PFTs work. But basically, just need to see reversibility of airway obstruction. And incentive spirometry, like I said, it's just one part of the PFTs, which is the forced expiratory volume, which is how fast you can breathe in 1 minute out. And we use it to monitor response to therapy. We used to use it more often, but I think now if you go to most emergency departments, you won't see it. Especially with the COVID pandemic, people became very cautious about using things that will aerosolize disease and viruses. And there's no evidence that it helps out. Because we used to use it as say, if I give you treatment, you're not doing better, maybe I'll give you more treatment, or maybe I'll admit you to the hospital because you're not responding to therapy. Okay, we do have adjuncts, and it's important to understand that most asthmatics don't need any testing. Because it's so prevalent, the disease, and how we figure out if you have asthma, we treat you and you get better, then we say it's asthma. But we use the adjuncts when we think something else is going on or we're worried about something else. But if you do these tests, what you do find in classical asthma, you may have some findings. Like you may see some hyperinflation, you may see some emphysema, and especially if it's poorly treated asthma for many years. Blood gases are not recommended generally. It's almost always the wrong answer to say blood gas in asthma, even for very severe asthma and someone who's very sick. Because the blood gas is usually trails the clinical manifestation. You can be dying from asthma, and your blood gas is normal, and you can have a very abnormal blood gas, but clinically still be well. So it's not very useful in that sense. Hypersensitivity testing of the skin is sometimes used to identify atopic agents. That's an outpatient setting. Sputum and IgE levels in sputum and blood can be also monitored. Nitric oxide levels can be monitored. This is usually outpatient monitoring as well. Not really something we use in the emergency department, more so in maybe a pulmonology clinic, or if they're difficult to control asthma. So how do we treat asthma? Well, it's important to understand that there's a non-pharmacological, a huge component of this non-pharmacological treatment of asthma. And the most important one is reduction of exposure to allergens. I mean, I'm sure you know someone who's asthmatic and smokes or sits around smokers, it's, or or whatever they do. They expose themselves to allergens that worsen his disease. So that's the first aspect is you need to reduce exposure or avoid exposure as much as you can. You have to identify the irritants and basically cut that out. It's important to also understand the role of infectious disease in asthma. If you go back to the COVID pandemic and you looked at who were the majority of patients who died from COVID, obviously it was the comorbid patient, but what was the number one lung disease associated with mortality in asthma and COVID was asthma. So asthmatics were the most patients who died during COVID from people with pulmonary disease and COVID. So that's why we vaccinate people. And one of the biggest, one of the most, one of the biggest populations that are at risk are the asthmatics for all viral infections. Same thing with influenza. So everyone's supposed to be vaccinated from it, but definitely the asthmatics, because they get the sickest when they get any viral respiratory infection. What may make you very sick might kill them or might put them in the hospital. So that's why we advise for routine vaccinations for viral infections. Healthy, clean environments make a big difference. It's definitely been associated with increased rates of asthma if your environment is not clean. And then using that with secondary prophylaxis, which we'll talk about, you can control the disease. So how do we treat asthma? Well, there's two classifications of medications. One is the rescue agents, and then the other one is the long-term preventative therapy. So rescue agents are medications used to treat the acute exacerbation, and they relieve the acute symptoms. They don't actually fix the disease itself; they just relieve the symptoms. The mainstay of that being the bronchodilators, beta agonists. They come in two flavors. We'll talk about that. There are other rescue agents such as anticholinergics and methylxanthines. Talk about that. Then the control arm medication, which is used to modify disease and decrease rates of exacerbation. They prevent you from getting sick and prevent the long-term disease itself, which are, glucocorticoids, leukotriene inhibitors, prominins, and IgE therapy, anti-IgE therapies. The beta agonists. The beta agonists are the mainstay of Ventolin, salbutamol, البخاخ الأزرق, as they like to refer to it. Two formulations, short-acting and long-acting agents. They work on the smooth muscles in the airways, and they basically cause broncho relaxation. There is some theory about there's some anti-inflammatory effects to it, but I'm not going to get into that. But really, they don't actually cause any chronic changes to the airway or help with inflammation. Like I said, the most common agents are the short-acting agents. And if it's you can get it over the counter. A lot of places in the world, you can't get these over the counter. You have to have them prescribed to you. And the only time you give someone a beta agonist on its own is if they have they have mild intermittent asthma, such as people who have asthma, exercise-induced asthma, or people who have asthma seasonally only when they have like URTIs or influenza, like it's once a year, twice a year. Those patients can be maintained with just a beta agonist. But for most patients, if they need to use they need rescue therapy more than twice a week on average, then they should be on inhaled corticosteroids. And that's an important number to understand, is that most patients with asthma do likely need to be on inhaled corticosteroids or control therapy. So the other aspect is a long-acting beta agonists. These are basically the same thing, but they just work on a longer period of time. They used to be prescribed in isolation, but now you can't get that as an isolated product because they found that people who use them on their own had increased mortality because basically they felt better, but the disease is just still active. They just feel better. So they were much more likely to have severe exacerbations of asthma and higher mortality, with multiple studies that show that. So now they only come as combination with steroids. So that's just important to know. Now, a big aspect of rescue therapy is that people actually don't know how to use a lot of the metered-dose inhalers. And even amongst people here in the room, I'm pretty sure many of the students here don't actually know how to use a metered-dose inhaler. So they're actually part of what you need to do in the emergency department and in the clinic is teach the patient how to use it. You need to know yourself. So the nurses are often educated on that and how to walk patients through using a metered-dose inhaler, so you can inhale the powder in and the steps. If you have an older or younger patient who can't do that, obviously, then what you do is you get them an air chamber and a face mask. So that way they just have to breathe in the particulate matter from the face mask and air chamber, so it will reach the lungs. They don't need to know how to use the puffer itself. The beta agonists are very safe agents. The side effects are usually some palpitations, tachycardia, not much more than that. That's generally the main side effect. And it can cause some anxiety in patients due to palpitations, sympathetic surge, but it's pretty short acting. Some people really don't tolerate those symptoms. Most people are okay with it, but that's just the main side effect, which is quite benign. The next line of therapy is anticholinergic therapies, and these are work on the anticholinergic receptors and cause smooth muscle relaxation. The main agents are ipratropium and gipratropium. Mostly, we use these in rescue therapy. We don't use them. We don't send people home with these. They're not as effective as beta-2 agonists for rescue therapy, but they work on a different mechanism. So if you come to the emergency department, if you're using your inhaler at home and you're not working, this is essentially what I'm going to give you plus the beta agonist. I'm going to give you the same medication you get at home, plus I'm going to add an anticholinergic for rescue therapy. Yeah. Some patients don't tolerate beta agonists. We'll prescribe these medications for them. To go home with. So they have a lot more side effects, the anticholinergics. They taste terrible. They can precipitate glaucoma. They can precipitate bronchoconstriction rarely. They can cause urinary retention. In elderly patients, they can cause confusion. So there are some issues with them. The long-acting anticholinergics have no role in asthma, but they are very important medications in COPD and actually improve mortality. So all patients who have COPD are actually prescribed long-acting anticholinergics because they have significantly improved mortality with that. Next group of acute risk therapies is the methylxanthines. They're reasonably potent. We don't really use them that much anymore because they have a very severe side effect profile that points used to be used for status asthmaticus. They can cause toxicity, especially in renal failure. They can hemodynamic instability, hyperthermia, multi-organ dysfunction, and even death. You will see them in some countries, but I haven't never used the methylxanthines. We have a lot of better options as far as medications now. Anyways, just need to know that they exist. Then next, I think thing we need to talk about is prophylactic therapy. And the cornerstone of prophylactic therapy is corticosteroids. Corticosteroids have like broad anti-inflammatory effects, but when taken through a metered dose inhaler or an inhaled aspect, it works mostly locally on the diseased lungs. And they decrease the need for beta agonism, they decrease the inflammation and decrease the chronic symptoms, and they can even make the disease become completely controlled with no symptoms. They do take time to work. They don't work immediately. That's part of the thing. They take days or hours to work. But they have a sustained effect when they're being used. And just important again to remember that they're indicated. Let's just do this fraction. This looks better. That looks better. They're indicated for anyone who has to use their rescue therapies more than twice a week, then you need to be on an inhaled corticosteroids. Anyways, I'm not going to spend too much time on how they work. You can read more about it. But in theory, they may help the effects of the beta agonism as well. There are multiple formulations with different concentration of steroids and different potency. That's again not important for this talk. It's just important to understand when you're looking at a patient with asthma, you need to understand what the steroid is, what the concentration is, and how often they're taking it, because that gives you an understanding of how severe the disease is. Because obviously, as the disease is more severe, then the concentration of steroid will increase and the dosing will increase. So someone who has to use a budesonide, 100 milligrams BID is not the same as someone who needs to use a beclomethasone 2 puffs or 4 puffs twice a day, because that's a much more increased amount of steroids. So systemic steroids. So we rarely use systemic steroids in chronic therapy, but we use it almost exclusively for patients with who have asthma exacerbations, and there's good evidence to support that. So if you have an acute exacerbation of your asthma and you need to get medical attention, then there's a role for short course of systemic steroids. It definitely helps mortality, morbidity, decreases relapse rates, decreases intubation rates when you're having acute exacerbations. Some patients have very chronic severe asthma and they need to be on chronic systemic steroids, and that just tells you the disease is very difficult to control, and inhaled therapies are not enough for these patients. Leukotriene inhibitors, now these are mast cell inhibitors. They work reasonably well. Sometimes use it as prophylactic therapy for people who can't tolerate steroids or have any side effects from them. And they do work in some types of asthma, like the patient we talk about with the aspirin-induced asthma. Those patients respond very well to this medication. They do have more side effects, not used as often. You just need to know they exist, and if you see that this patient is more unique in that sense of how to treat their asthma. Chrominins are not really used anymore. They're also prophylactic medications. Not as effective as the steroids or the mast cell stabilizers. They're taken through an inhalational route. You just need to know they exist. Yeah, but not often. IgE therapy is something you'll see more and more. So now you'll see a lot of patients. They أنا آخذ إبرة للربو حقتي. And these are interleukin inhibitors. They work in the inflammatory cascade. They actually work directly on the interleukins that precipitate asthma. And they're quite effective. But we reserve these medications for patients who have like severe asthma who are difficult to control with the regular therapies. So if somebody tells you that I'm on an IgE therapy for my asthma, understand they have very severe disease and they fail a lot of therapy. So that's a high risk patient. You have to understand that. They're still mostly, I think the evidence is still mostly for patients who are adolescents and older. So they're not for kids. There are multiple different IgE medications at this point. They're still quite expensive compared to conventional asthma treatment, which is very cheap. And they can't cause tachyphylaxis. They can't cause anaphylaxis even if they've been taken many times. So they usually have to be given under medical supervision. So it goes to like a clinic or etc. or go to just to get it, and somebody needs to watch them after he gets the shot. So they're not sent home with these shots. So that's important to understand. So in the emergency department, we're interested. We sometimes diagnose asthma, obviously, because that's the first presentation, but mostly we see exacerbations of asthma. Patient who has had the disease and then comes in because it's gotten worse. And this happens. So we need to know which patients can we send home, which patients we have to keep in the emergency department. So generally, we need to know who's going to do poorly. So the patients who usually do poorly are patients who have multiple, obviously, exacerbations that are not well treated. They don't have good follow-up. Patients who overuse a lot of over-the-counter medications, people go buy a lot of their beta agonists and keep using them. Those are patients who will generally do poorly because they're not treating the disease itself. Patients who are not compliant to their steroids, who take their steroids and stop taking them, those patients do poorly as well. Patients who've been admitted before for asthma or ever been to the ICU or intubated, so those are higher risk factors that their acute exacerbation will make them very sick and they might die from it. And then patients who have, or comorbid, obviously, like they have chronic lung disease, renal disease, and they come with asthma exacerbation, likely going to do worse than someone who's healthy, obviously. So you have to think about these considerations when you see an asthmatic. So how do we classify asthma thought? Generally, mild, moderate, and severe. If anyone needs medical attention for acute asthma exacerbation, they're considered moderate by definition. And if you're managing at home, you're fine. You use your Ventolin when you feel a bit unwell and you're okay. But if you need to come to a healthcare facility for your asthma, then you're by definition a moderate exacerbation. Moderate exacerbation by definition always needs anticholinergic and always needs steroids as part of their treatment plan. And then severe, which is patients refractory to therapy or status asthmaticus. Those are a rare subtype, but an important one. So we have ways of actually stratifying the severity of the asthma itself. We don't use it for adults as much. In pediatrics, it's used more often because it's difficult to assess them subjectively, objectively. So we have scales to say are they better, are they worse? It's the work of breathing, etc. To decide should I give them more therapy, should I admit them, can I send them home? So you'll see scales in the pediatric emergency department for asthma. So this is a very important slide. A big problem in medicine, and emergency medicine specifically, is that a lot of times we assume it's asthma when it's something else because we're basing it only on maybe history or basing it on an exam or basically on wheezing, which is a big one. We assume that anything that wheezes is asthma because it's so common. But a lot of things that are wheezing associated or increased airway sounds are not asthma. And there's some very serious conditions we fail to recognize. In pediatric patients, often things we tend to miss are anaphylaxis, foreign body aspiration. All these come with wheezing. In older patients, we fail to consider things like CHF, which can wheeze as well, malignancies, which can cause wheezing as well. So it's important that the history and the physical exam are consistent. And if you're not sure, then we start doing the adjunct testing, which we talked about, the chest X-ray, the blood gas, the renal, even the CT chest, PFTs, etc., etc. But you have to consider other dangerous diagnoses when you're with someone who has wheezing as a part of their presentation. How do we treat, like I said, asthma? Well, then mostly for acute exacerbations, it's mild to moderate exacerbations. They get, obviously, is Ventolin, the beta agonist. And it's important to understand that it's been studied that whether you get the nebulizer versus the meter dose inhaler, اللي هو face mask مع الغداد, versus the MDI, which is the البخاخ, it's the same effect. It's the same dose. People feel that one is better than the other, but the evidence doesn't show that. The response to therapy is the same. So if I give you 4 puffs of Ventolin versus one face mask, which is 5 milligrams of Ventolin, the effect is the same. There's no difference in outcomes. It just people prefer the face mask sometimes because they don't want to put the effort. They feel that it's different than what they received at home. It's more psychological than actually medical effect. So if you have in an emergency department, you're going to get some beta agonist and an anticholinergic as a puff or as a face mask. And you should get some steroids. Steroids, doesn't matter if you give it oral, IV, it's the same effect. So generally, if they don't need an IV, they don't need an IV. Most asthmatic exacerbations don't need IVs. They just need oral medication and MDIs. Now, for a subset of patients that are very sick, the guidelines still say magnesium, although most of the recent evidence suggests that magnesium doesn't have any effect. So likely you'll see updated guidelines say there's no benefit of magnesium. Other things we can offer these patients if they're very sick for their asthma is there's some IV medications that have been shown to be effective. We can give them IV Ventolin. It's very expensive and difficult to dose, but we can do that. We can give them IV epinephrine that's also been shown to be effective. There's a sedative called ketamine that's been shown to be effective in asthmatics, which you can use. It decreases bronchoconstriction. And in some patients, they're very hypoxic, so we put them on oxygen. And if they have in very increased work breathing, we put them on non-invasive ventilation or a BiPAP machine. Some patients are very, very sick and they don't respond, and we end up putting them on a mechanical ventilator. Obviously, the mechanical ventilator works through positive pressure ventilation, pushes air into the lungs, and the asthma patient can't breathe air out. So it's a very high-risk procedure putting an asthmatic on a ventilator because there's a good chance they will die once you do that. So we try to avoid it as much as possible unless we have no choice if they've stopped breathing for the very severe asthmatics. So I just think some take-home points for this talk is most patients suffering from asthma are poorly controlled. If you need to do beta agonists more than twice a week, then you need to be on a control agent. Long-acting beta agents are not used in isolation anymore. They're used in combination. And magnesium used to play a role, but now it's really fallen out of favor. Not the evidence support its use. That's it. Do you have any questions regarding this talk? Now's the chance. And I prefer just type this, and if you need to ask, it's fine. See you later.